Good evening, everyone. Can you hear me well?
Yep.
Okay. I'm Dr. Dharmesh Mehta. I'm the president of APNO. I would like to welcome you all to our first webinar of this year. We are lucky to have speakers from CDC and CVD. This webinar is also running on our Facebook page. It is also being telecast at NeoMed, SUMA, and Accurate General Hospital. So first of all, I'd like to invite our BOD chair, Dr. Bijadi Mukunda. Dr. Mukunda has served as Chief of Staff at Cleveland Clinic Hillcrest Hospital. Currently, he is also leading the Department of Medicine. He is also Chief Medical Officer for CareSource. So over to you, Dr. Mukunda.
Thank you, Dharmesh. Welcome, everyone. Good evening. Welcome to our distinguished speakers this evening. It's my distinct pleasure to welcome you all. As you know, APNO is a voluntary not-for-profit organization that was established in 1983 with the sole purposes of serving the community, furthering education and research. And our community activities include local, national, and international efforts through Medical Yatra. Our education and research, our members are very active in local academic institutions, including Cleveland Clinic, University Hospital, Metro, just to name a few. Thanks everyone for taking time and to understand the implications of vaccination to protect our community and to further education and research. Thank you.
Thank you, Dr. Mukunda, for a great introduction for our organization, APNO. Now, it is my honor to introduce Dr. KASHMIRA Datte. Dr. Datte is a medical officer at Center for Disease Control and Prevention. She is also epidemiology team leader for 2019 coronavirus response. Please welcome Dr. Datte.
Thank you, Dr. Mehta, and wanted to thank Dr. Rena, Dr. Mukunda, and all of the organizers for this, for inviting me to present today. I'm just going to give me a minute. I'm going to share my screen. Can you see my full presentation?
Yes.
Yeah.
Okay, wonderful. So again, thank you very much. I'm on the international task force of the CDC COVID response task force here. I'm just going to talk a little bit about the global COVID-19 epidemiology before turning it over to Dr. WILBUR CHEN for the vaccine-related updates. So before I talk about all of the data and what I'm going to be presenting, just wanted to give a little bit of a disclaimer here. As you know, the situation is quite rapidly evolving. These data are available, but are going through some data cleaning. Verification is ongoing, and so there may be again some representativeness issues, as there are only a small proportion of cases that get reported. So I just wanted to present that. So just very quickly wanted to go into what the global epidemiology situation looks like for COVID-19 deaths and cases. As you can see here, as of yesterday, we have actually about 103 million cases now globally, and over 2 million deaths that have been reported. In the last 24 hours itself, we do have over 200,000, 279,000 cases reported and over 7,000 deaths reported. So it's a pretty grim situation. As you can see here on the figure on the left here, that's the epi curve that we see globally, and then also it is by WHO region. So you can see here the region of the Americas and the European region remain the most affected regions globally, and the same applies for deaths as well. This small table here on the right bottom, what it shows is what is the average daily incidence looking at the past 7 days, and then what is the change in the weekly cases. So although there may not be it may seem like some of the case numbers are decreasing on a weekly basis. We do see that the average incidence is actually pretty high, especially in the region of the Americas and the European region. This just very quickly shows the epidemic curve by region. As you can see here, the patterns seem quite different in multiple regions. Africa is notable here because we have seen a relatively low incidence earlier, but it also depends. I'll go into this in more detail in terms of what we see regarding testing capacity. In terms of Southeast Asia, as you can see, the numbers earlier were relatively high, but now we are seeing some declines in the region as well. This is another way to see what the global map looks like. And this is, again, the 2-week incidence and the case counts by country. So the red dots indicate what is the 2-week cumulative confirmed case numbers. And then the shades basically show what the incidence looks like when you look at the number of cases per 100,000 population. So again, as you can see here, a majority of the cases in the Americas region and Europe. But I think I just wanted to point out here, South America, as you can see, has been quite a bit of a hotspot here, along with what we see in Southern Africa. So again, this is how we monitor the data in terms of what the burden is looking like, and whether, so we call this as the case trajectory map, looking at the disease burden and whether it's growing or whether it's stable over a period of time. And again, as you can see, the patterns are quite similar. And just, a quick reminder, now this is a cumulative map that shows the overall numbers in terms of the 100,000 cases per 100,000 population. And again, when you look at the cumulative cases, we do see that same pattern, Europe and the region of the Americas. It's notable to see in some of the high burden countries. In India, for example, initially there were quite a few cases, but now we are seeing the cumulative case numbers decrease overall. This is the map that shows COVID-19 deaths per 100,000 population. And it's very similar to what we see in terms of case numbers, but also I think the deaths are striking, especially when you see in the region of the Americas, South America, especially Southern Africa, although the case numbers didn't seem that high. I mean, the deaths, it's a pretty grim reminder of the number of deaths.
Sorry, Dr. Dave, I don't think we can hear you. There's some. Is your mic is on?
Something happened. It was coming, stopped.
Yeah, suddenly something stopped. Let me see. You are not muted, so that's not the reason.
Dr. Date, we cannot hear you.
Yes, she's working on that. She knows that. I think. Can you mute and unmute yourself again? Let's see if that works.
Okay, can you hear me?
Yep.
Yes.
Yeah, it's coming through now.
Okay. Okay. All right. Sorry about that glitch. So I was just showing here the age and sex pyramids for the number of confirmed cases and the confirmed deaths that have been reported globally. So as you can see here, the majority of the cases are in sort of the younger age groups, especially when you look here in the 20s to the 50s age group. But when you look at the confirmed deaths that you see in the older age groups. So this very clearly shows where the transmission and the morbidity and mortality is happening. So when I mentioned earlier, now these are all of the reported cases and reported deaths that we see, but we really need to think about it in the context of what we see in terms of lab testing. Now this map has improved compared with what we saw in a few months ago. So the testing capacity, especially in regions like Africa, especially in Southern Africa, has improved. But as you can see here, the lighter shades, these are the number of tests that have been done per 100,000 population in the past 30 days. So, again, the capacity is still pretty limited. There is less testing that is happening in many of the African countries. So another way that we monitor what's happening in terms of considering the testing is looking at the test positivity rate. So even when there is less testing happening, less number of tests are being run, the test positivity shows us really what the situation may be. So as you can see here, because limited testing makes it likely that many cases will be missed, the positivity rate can help us understand the virus spread. So in countries with high positivity rate, the number of confirmed cases is likely to represent only a small number of the true infections that are happening in those countries. So that is something that we really need to consider when we are interpreting these global numbers. This is a little bit older in terms of the data that is presented. What we present here is the cumulative incidence of confirmed cases versus what is the seroprevalence in these countries. So as you know, there are a number of serology or seroprevalence studies that are happening in multiple countries. So that is basically to look at whether infection may have occurred at any given point in time. So what we see here is that the cumulative incidence of confirmed cases is actually much lower compared with what we have seen in terms of seroprevalence. So that gives us an indication of how many cases we are missing, how many infections we are missing, and what kind of testing, what kind of the testing data show. So just very quickly now, which everybody is I'm sure quite anxious to look at what is happening in terms of all of these variants that are now being reported. So I just wanted to remind everyone, and as a physician group, I'm sure you're all quite aware, but this is what we see. So it is normal for the viruses to change over time. So when you're seeing all these variants that are being reported, that is something that we have been expecting, that there will be emergence of new variants as the virus continues to replicate and it continues to spread. There will be new emergence of variants. So we see multiple ways in which these variants may impact what's happening. So most of these mutations that occur that cause an increase in these new variants, they have no impact on the virus itself. Some may be actually harmful to the virus's survival, and so it may actually decrease how the virus survives overall in different kinds of hosts. Few may actually result in an advantage to the virus, make them more transmissible, increase disease severity, or influence on vaccines and therapeutics that we'll hear about a little bit later. But when these viruses increase the risk to human health is when we consider these as variants of concern. And so when you see these variants are being reported, they are reported in different formats. So, variants, emerging variants, variants of interest, which means that we really need to follow those variants very closely, and then the variants of concern, which basically show that when these mutations are being monitored, there may be an implication to what is happening in terms of the spread, in terms of what it may be causing with severity, and implications for therapeutics and vaccines. So again, as I mentioned, the potential for these virus mutations increase with the frequency of the human and animal infections. So the more we give the virus a chance to replicate and transmit, the more is the potential for these virus mutations to increase. We also know that the SARS-CoV-2 virus tends to change more slowly compared to the other RNA viruses, such as influenza viruses. So that is something that is a little bit more reassuring. So what is happening in terms of the new emerging variants of concern? So this is what we've seen. The WHO and several CDC and several other global partners have been monitoring these variants quite closely. So these are what are the variants of concern or the variants of interest that have been determined. So early on in September last year, as you may have heard from the news and in different outlets, that a variant that emerged in Denmark that was related to mink farming. The more concerning ones that we are now seeing in the UK, South Africa, and Brazil are the ones that I will talk about a little bit more. So the variant that was detected in the UK in December of last year, another variant emerged in, which was first detected in South Africa in December 2020, and then a variant that was first detected in Japan among persons that were traveling back from Brazil. And now we are seeing the similar variant in Brazil as well, with some slight differences. So all of these variants basically involve genetic mutations coding for the spike protein. And because the spike protein is what is being targeted by most vaccines and therapeutics that are in development, those are the mutations that are being most closely monitored. Now, again, we are trying to not use the country names to identify these variants, because although these countries may have been the ones that first reported these variants, we don't know how much earlier the variant was circulating and in which country. So there are different ways in which the variants are named based on the name of the variant, its lineage, and things like that. So I will refer to it in that format. So this is the map that shows the variant 1 that was first reported in the UK. As you can see here from the global map, it has now been verified in about 75 countries, reported to WHO, and a few other countries are under verification for this one. This is the other variant that was first reported in South Africa, and now it has been verified in 34 countries and is under verification in 6 countries. The third variant, which was first reported, like I said, through in travelers coming from Brazil and reported by Japan, has now been verified in 10 countries. And this is what we are looking at very closely in terms of the P1 variant is how it's called. So in the interest of time, I'm just going to very quickly mention what we know currently. And as I mentioned earlier, all of this information is rapidly evolving, and a number of global partners are trying to very closely monitor what's happening in terms of disease transmissibility, disease severity, the impact on vaccines, the impact on diagnostics, and the impact on therapeutics. So this slide basically just summarizes what we know currently in terms of these different variants. So the one that was first detected in the UK, the B117 variant, that has the most data that has been reported right now. So we have seen increased transmissibility from studies that were done through contact tracing mechanisms and some household transmission studies that were done. It does seem like the variant is showing some increased transmissibility. Preliminary data on disease severity also suggests that there is an increase in disease severity from some of the mortality data that has been reported. But again, this is preliminary, and more analyses and more data are being reviewed in that sense. I'll let Dr. Chen talk a little bit more about the implications on vaccines, but the preliminary data are suggesting that the current vaccines should still be working. There is some data that show, a little bit of a reduced effect on virus neutralization, on neutralizing antibodies. But again, that's way above the threshold, and I'll let Dr. Chen talk more about it. The P1 variant in Brazil, as you can see here, we just really don't have very much information on these variants and the impact on these different factors that we are monitoring. So more studies are happening and more data are needed. So I just want to mention that all of the studies have shown that the mode of transmission of the virus variants hasn't changed. So the same preventive measures that have been advocated for and what we are asking to do should still be continued to be implemented. The masks and the social distancing and all of the public health and social measures should still be working. And just this is, very quickly, I wanted to show this slide before turning it over to Dr. Chen as a segue to his vaccination presentation. This is a remarkable achievement that we have seen within almost just about a year since the vaccine, since the virus, since the pandemic has been announced. So vaccination is now underway in about 72 countries. As you can see here, these are now the vaccine doses that have been administered per 100 persons in multiple countries. So the topmost here are Israel, the UAE, UK, US, and Bahrain. And then, of course, multiple other countries have started their vaccination campaigns. And I just wanted to show that there are several resources that are available on the CDC website, including the CDC global website, WHO resources. A number of resources are available there. And then some other useful resources that I'm sure people are already familiar with. And with that, I'm going to end my presentation. Thank you.
Thank you, Dr. Datte. It was excellent presentation. A lot of good information about COVID-19 epidemiology, especially with the new strain, because that's what we need to be spreading around now, and then we need to know more about that. So now I would like to invite Dr. Neil Mehta to share his view. Dr. Mehta is a professor of medicine and associate dean for curriculum affairs, Cleveland Clinic Learners College of Medicine of Case Western Reserve University. He is also Endo Chair in Medical Education, Cleveland Clinic. Please welcome Dr. Neil Mehta.
Thanks, Dharmesh, and thanks, Dr. Tate. That was a great summary. Thank you for bringing us up to date with all the data. I think it's a fantastic testament to how the countries are sharing not just their data, but the knowledge. And I think, we have to remember we live on one planet, and we can't beat this disease country by country. We have to work together to do this. And I know there's a lot of students on the call, and my life, part of my life is about medical education. And I have to say, if you have not thought about epidemiology as a career choice, you have a role model right here in front of you. Think about doing an MPH and, touch base with Dr. Tate maybe, and she can tell you how such a key role is being played right now across the world by people who are epidemiologists and virologists. I think just wanted to make a point that, as we look at the world and we saw those beautiful global distributions of diseases, vaccination rates, it's a great way to study. It's a natural experiment that is happening. These are experiments we can't do. But if you think about some early on, before we had therapeutics and vaccinations, we had some countries that succeeded in basically zero COVID, right? And got to zero COVID. And you look at the non-pharmacologic interventions that they used. And they are great examples for what may work. And now I think it's even more interesting if you love basic science and immunology and vaccines. There are multiple vaccines, and many countries are using different strategies for how they're rolling them out. You look at Israel, and it's way out there and has vaccinated almost, I forget, 70 to 80% of their seniors, and a huge drop in the number of new cases, hospitalizations, and deaths in the older people compared to the people less than 60 who have not been vaccinated. And Israel, as you saw in Dr. Date's map, does have the B117 variant. So again, like she said, it's reassuring. The vaccines are probably going to work, and they worked in Israel, and that's our natural experiment right here. And the same thing in South Africa. They were doing phase 3 trials while with Johnson & Johnson vaccine, I believe. And we have data from there saying, most likely we are okay. They may not do as well, but no one who has been vaccinated has died of COVID yet, of any of the vaccines. And I think that is very, very reassuring. So thank you, Dr. Date, and great, great talk and great role modeling for all our medical students to follow your footsteps. So I'll turn it back to Dharmesh.
Thank you. Thank you, Dr. Mehta, for your great input. Now let's move on to our next presentation. We'll take the question at the end for Dr. Date. It is my pleasure to introduce Dr. Chen. Dr. Chen is infectious disease physician-scientist with a special interest in clinical vaccinology. He is a professor of medicine at University of Maryland School of Medicine. He is chief of adult clinical study section, Center for Vaccine Development. He is also director of University of Maryland Trial Medicine Practice. Please welcome Dr. Chen.
Thank you so much for having me. And I really just want to thank you for the conference organizers for putting this together. Hopefully I'm sharing my slides right now. And I have just a selected few slides to give a wide overview for the context of how we develop these vaccines. But I think I wanted to allow for a lot of time to have question and answer so that we can go more in depth into some of the vaccine specific questions that you might have that I won't be able to cover in a talk of this length. So let's see. So I have just a few disclaimers. So I am a member of the ACIP, but none of these views are reflect the official policy of the CDC. I'm also a employee of the state of Maryland through the University of Maryland. And so I'm not also voicing anything from the government of the state of Maryland. So let's see. So usually when we develop vaccines, it's a whole gamut of activity that takes about 10 to 15 to even 20 years. And it really is oftentimes a vaccine being developed in the first place depends on the political health need, the public health need, which means, again, it has to have some value for public health. And there has to be a market need. Usually it's driven by, again, for these pharma industry, their perception that they will be able to recoup their losses that they put into the R&D development. And of course, along the way, there has to be kind of political will power to be able to make this vaccine get all the way through. In this instance, we were able to make a selected set of vaccines within remarkable time, within less than a year. And so how did we do it? A lot of it was because we took away the market need, which basically meant that through Operation Warp Speed and at the global level, the WHO, COVAX, and other programs basically poured in huge sums of donated money to be able to make the case that we could have these vaccines accelerated without having to have any financial determinations as to whether or not there was a milestone that needed to be approached to be able to develop the vaccines further, okay? So let me go through all of these steps so that we can understand how these vaccines were developed so quickly. So first of all, for a vaccine to be developed, you usually spend quite a few years in the discovery phase. In this case, we took advantage of some broad-based vaccine platforms to be able to develop these vaccines. And they are basically those future approaches that you see at the bottom of this figure here. So the traditional approach is like, say, for example, influenza vaccine that's been made for many decades is still made, believe it or not, by embryonated hen's eggs. And that's how we replicate large numbers of the virus to then be deactivated, centrifuged, purified into the vaccines. There are newer approaches that we use that are represented by a number of licensed vaccines. So live attenuated vaccines are represented by, say, for example, measles vaccine, yellow fever vaccine, etc. These are live but weakened viruses. There's recombinant protein approaches in which the hepatitis B vaccine is a recombinant expression of the B hepatitis B surface antigen, and that's recombinantly expressed by E. coli. There's cell culture-based approaches. So again, getting away from embryonated chicken eggs, where you can use purified cell cultures that are highly characterized and be able to replicate the viruses to a large amount. And then now we have very immune stimulating adjuvants that allow us to make vaccines much more immunologically potent. So for example, one of the great reasons why Shingrix vaccine is so successful is because it has an adjuvant that is in the vaccine that makes it very successful. Now, the future approaches are what we're seeing right now for a lot of the vaccines that are being developed for COVID. mRNA and DNA-based vaccines, where you basically, as soon as you sequence the virus, you can pop in those gene sequences and be able to make those vaccines based on this platform technology. You can have virus-like particles, virosomes, and even nanoparticles in which you're coating them with proprietary lipids or other things, and those could be viable vaccines. And then there are the viral vectored vaccines, which are represented by taking another virus, like a chimpanzee adenovirus or human adenovirus, and putting in the sequences for the spike protein of COVID to be expressed, and that would be a viable vaccine. So these are the vaccine platforms that, again, were already under research for many years before COVID happened. And so we basically took advantage of these broad-based platforms to be able to make these vaccines, so there was not a lot of time needed to be spent on the discovery phase. So once we did embark onto human clinical phase 1, 2, and 3 studies, those are pretty standard studies, but here in the US, we had Operation Warp Speed and others that were working in a collaborative level on a national level. And basically, we were able to generate universal protocols for all of these vaccines platforms. And basically, we were able to perform the phase 1, 2, and 3 studies with very much the same outcome measures in mind, using the same assays, so that, again, we could have these vaccines performed, evaluated relatively quickly, using those standardized technologies and approaches. Another thing that also helped us along the licensure pathway as we were evaluating these studies is that the FDA very early on came out with guidance for the industry to be able to state what are the milestones that need to be demonstrated for a vaccine to be successful and to potentially be licensed. And some of the things that they put in their guidelines, which was very important, was that they made it clear that the populations that these vaccines would be evaluated in had to represent the general population and the high-risk parts of the population, which is why you're seeing that the vaccine efficacy studies are being done not just in healthy young adults, but older adults and also adults with multiple comorbid conditions that represent all of the medical conditions that we understand are the high-risk conditions for severe disease for COVID. Also, the efficacy had to be demonstrated so that you could prevent symptomatic lab-confirmed infection. Also, we wanted to look at additional outcome measures that looked at more severe disease. And also the statistics for the studies that had to be performed had to demonstrate an efficacy of greater than 50% for these vaccines to be successful, which may sound low, but in comparison, influenza vaccine from year to year has variable efficacy, but it's anywhere between 40 and 60%. So for us to have a vaccine that's 50% efficacious was what FDA set as the milestone very early on. And for the statistics, the lower bound of the confidence interval had to be greater than 30%. So again, that showed you that there was quite a bit of detail that was provided so that as we developed these vaccines, we knew what we needed to do in order to achieve a successful vaccine. So here are the global vaccines and their different characteristics, and I just tried to summarize them in very brief so that you could see them. In the orange box here, you can see these are the 5 US vaccines that are either already emergency use authorized. The two known as the Pfizer and the Moderna vaccine, these are mRNA-based vaccines. And then the additional vaccines that are under advanced development, which J&J, of course, just filed their EUA application yesterday to the FDA. And this is based on an adenovirus type 26 vectored vaccine. The AstraZeneca is approved for use in the UK and in Europe, not in the US yet, and we don't know exactly when they will be filing to our own FDA, perhaps in a month or two is what we're being told. But this is based on a chimpanzee adenovirus vectored vaccine. And lastly, you probably heard about the recent announcement press release of the interim efficacy for Novavax, and that's based on a nanoparticle that is being administered with an adjuvant. And this nanoparticle basically has a lipid coating around it and has an immunostimulating adjuvant that's also associated with this vaccine. And so you're seeing that the efficacies here are variable, but they are pretty much on the order of what I said was they had to be 50% or higher is what the FDA put as the benchmark. There are other studies around the world. So Russia has a couple of vaccines. There are at least 2 different vaccines that are basically being launched from China, Chinese companies. And then there are 2 additional companies in India that are launching their own vaccines. I haven't heard much more about Cadila, but they are also developing a DNA-based vaccine, but I haven't heard any advanced efficacy data from this particular product as well. But again, what I'm trying to show you is that using those broad-based vaccine platforms, that a number of different COVID vaccines are being developed and are viable in showing efficacy. And the efficacy is actually very remarkable, very heartening in that many of them show extremely high efficacy, which we did not think that we were going to achieve at the beginning. In fact, I myself commented to my own colleagues early on that if we get vaccines that show 70% efficacy, I'll be extremely happy because that's what I thought would be the best scenario. And boy, was I proven wrong when we started seeing 95% efficacy with the mRNA-based vaccines. So some of the questions that I field are, what are the side effects that we're seeing so far? So cumulatively from the studies that have been performed with the mRNA-based vaccines, and these comments are really for the mRNA-based vaccines because those are the published studies from the US that we've seen so far, is that you can have localized pain, swelling, redness at the injection site, and you can have some more systemic reactions. Usually they're mild or moderate. Some of them are a little bit more severe, but they are self-limited and they usually go away within about 3 days maximum. There is a potential risk, and it's a rare risk, excuse me, of anaphylaxis. And the order of magnitude for this risk, so that you know that it's rare, is about 2.5 cases or 5 cases per million doses that have been delivered. So for context, I try to provide for you what that means. For influenza vaccines, we understand that anaphylaxis risk is about 1.3 cases per million doses. For penicillin anaphylaxis, it's about 1 case of anaphylaxis per 5,000 people who declare that they have a penicillin allergy of any sort. And for foodborne anaphylaxis, it's about 1 or 2 cases of true anaphylaxis per 100 people that declare that they have some sort of food allergy. Okay, so again, I'm trying to communicate to you because you're basically the public health people to your local communities about what risk really means when they ask you about risk. This is how you contextualize this ability to articulate what risk really means. Now, the opposite side of that is, what if you don't get vaccinated? Because they're basically asking you to weigh the risk versus benefit of getting vaccinated when they ask you about risk of vaccine. So you need to tell them the other side of the coin, which is, well, here's the risk if you don't get vaccinated. If you're fearful about vaccination, I told you about the risk there. Here's what you need to fear if you don't get vaccinated. Of course, there's symptomatic disease, which is very variable. It could be anywhere between 40 and 80%. And of course, healthy young adults have less risk of symptomatic disease. They usually have more asymptomatic disease. There's anywhere between 5 and 10% risk of hospitalization. And there's maybe a risk of about 1 to 2% of death. And that might be an overcall because, again, we understand that there are a lot of people that have very minimally symptomatic disease. And so we're not really counting those necessarily very well. But anyways, that gives you an idea that there is real risk associated with not getting vaccinated. There's also the long-term consequences potentially, or other consequences of surviving COVID, which is you could have blood clots, you could have a heart attack and stroke and secondarily die from those. You could have permanent organ damage. You could have distorted or loss of your taste or smell. We know about the long haulers kind of effects, psychiatric or mood diseffects or effects, and hair loss, to name the least. So again, those are the things that, again, we want to communicate when someone asks you about risk. Now, words about efficacy. So in our studies, we really only have the best estimates for what is the efficacy against symptomatic disease after 2 doses. And it's after 14 days from the second dose, because that's when you see the peak of the immune effect. Now, if you look at these curves here for both the Pfizer and the Moderna vaccines, these risk curves really show that even after a single dose and before that second dose is administered, this curve is very flat. This curve is very flat for vaccinees in both of these studies. So what you can see is you really can get that hint of that there is true efficacy after 1 dose of vaccine, but we really don't have the answer for how prolonged the duration of protection is after a single dose. We really only know the duration of efficacy after those 2 doses. So we don't know if those curves would significantly change if we did not administer that second dose. But it gives us a clue as to the short-term efficacy. And so I think that that fuels some of the international discussions for the policy decisions for administering that second dose out to maybe even 12 weeks after the first dose, which is not what we've decided here in the US, unless we need to. Now, there is the flexibility certainly for implementation purposes, but again, that's not the policy decision that we've made as a whole from the CDC's ACIP. So here I'm giving you efficacy, and I'm just making this guess that it's anywhere between 80 and 100%, 80% efficacy after that first dose. But again, I don't know how long that duration lasts, and that estimate has wide confidence intervals. Now, I also put here efficacy against severe disease. Now, if you look at those studies carefully, severe disease was defined by hospitalization, death, but also by desaturation and oxygenation below 93%. Now, there was 1 case of a vaccinee among those 2 studies of tens of thousands of people where they qualified for severe COVID infection, okay? So that's why I say that the efficacy against severe disease is nearly 100%. That 1 case was a case that technically qualified because they had an oxygenation of less than 93%, but did not require hospitalization, did not require any other medical intervention. So again, what I'm trying to give you the idea of is the value of these vaccines is not simply that efficacy that we keep quoting of 95%, which is only a protection against symptomatic disease. But if we have vaccines that actually turn this infection into just mildly symptomatic illness and prevents all hospitalizations and all deaths, we have an incredibly valuable set of vaccines. So I just wanted to make sure that you understood what we really mean when we throw around these words efficacy, because efficacy in the context of these studies was the primary outcome against mildly symptomatic disease. But the true public health value of a vaccine is whether or not we can prevent people from flooding the medical system because they need medical care, hospitalizations and deaths, or complications due to COVID. So again, we didn't measure that very well in the context of these studies because that was not the primary outcome measure. But as I said, it's nearly 100% by these studies. we did not measure asymptomatic disease, and so we don't really know about the ability of these vaccines to prevent transmission. I think we have a hint of that, but I can't give you numbers of efficacy. So again, I'm just showing you that that's the spectrum of how we develop these vaccines so quickly through phase 1, 2, and 3 studies. There was a lot of thought that was put into the policy and implementation of these vaccines. And again, we're all dealing with limited supplies of these vaccines right now. So we're all trying to allocate these vaccines to prioritized populations. When we talk about prioritized populations, realize that we're trying to basically eke out the maximum utility of these vaccines. We also are trying to discuss amongst ourselves, perhaps locally you've been involved in these discussions, but certainly on the national level, this was a very robust discussion of making sure that we did it in an equitable manner that basically was ethical as well. And that the national guidelines were developed so that you would have local jurisdictional flexibility to implement these vaccines. We also, of course, are all kind of dealing with all of the logistical nightmares of these different vaccines. And we're hoping that, the J&J vaccine will present a much more easy to deliver logistical vaccine. And of course, all of us have to have a strong public health message for the value of these vaccines. So again, my message is, we are all trying to maximize the benefits, minimize the harms, and try to have equity, justice, and fairness built into our framework for allocating these vaccines. We need to do it in a transparent manner. And as I've been trying to show, I try to do it in an evidence-based manner as well. And we need to also think about how we do this in a feasible implementation manner. So here, again, all of you are probably dealing with this, but we're right now at this initial phase where there's limited vaccine available. We're trying to target our immunization to prioritized populations. Hopefully, into the late winter and early spring, we'll have more and more vaccine becoming available to the point that we'll have plenty of vaccine available. And at these points, we will start to surge more and more in our capacities to be able to deliver these vaccines. More and more, we're going to be using these more innovative and broad-based delivery approaches, which is using national pharmacy chains, maybe individually owned pharmacies, maybe dental offices and clinics, maybe other places, maybe home health aides will be delivering vaccines. So again, we need to be able to administer these vaccines to the entire population, and especially thinking about difficult to reach populations as well. And then there's the final phase for us to consider, because there are going to be parts of the population that are still vaccine hesitant that we're working on right now, but still will continue to be. And so we need to continue to make sure that access is out there for these vaccines to immunize those that are not successfully vaccinated at the earlier phase. So meanwhile, while we're waiting for these vaccines to be available, we all need to communicate the importance of maintaining those NPI measures that we talked about, that Dr. Mehta talked about. And so again, those NPI measures are so critical. And in the absence of vaccines, that's all we have to do to depend on. And as a marker of the success of NPIs, I think all of us have seen, amazingly, very, very little influenza activity nationally, and I'm sure locally as well. So it's been quite tremendous that this entire pandemic, we've seen very little influenza. Variant viruses, Dr. Date already talked about them, but I thought I would just cover them as well. But basically these mutations, the ones that are critical are the ones that we see in the receptor binding domain. And again, what we want to not see are changes that change the fitness of the virus such that they become able to cause more severe disease, evade our testing, therapeutics, or vaccines. And this is the way that I illustrate it so that you can talk about it to laypersons, which is like facial recognition. And you think about, well, if you try to, put on a disguise, and each of these mutations can disguise the virus to a certain extent, you can have enough mutations such that our facial recognition will fail to see that same face and recognize it. So again, that's kind of my way of trying to illustrate to the layperson about why we're so concerned about these mutations in these variant viruses. And that's why these vaccines can't see the virus, because it hasn't been trained to see the relevant virus. All right, and so we have evidence that these vaccines that we're developing may have slightly lower efficacy. I don't know by how much, but these are the unpublished data from some of these studies that were performed internationally. And you can see for the South Africa studies, in which predominantly those were caused by the variant virus in South Africa. And you can see that the efficacies were documented to be lower in those studies. So again, I think it's no surprise, but again, we don't want to be alarmists. We want to make sure that the public understands that our vaccines will still continue to have very good efficacy. Maybe not 95%, but still very good efficacy, and will still be valuable for us to get out of this pandemic. So thank you so much for letting me talk to you today, and I hope all of you get vaccinated. I'll stop here. Let's see, how do I stop this? There we go.
What's the announcement?
Thank you, Dr. Chen. It was excellent presentation. It was very good information about the vaccination. And I'm agree with your point, about I'm practicing internal medicine, so we haven't seen any flu cases so far. So I think that strategy is helping for the flu pandemic, epidemic too. So now I'd like to introduce our moderators. And then if anyone of you have any questions, please type in the chat box so they can prepare the question for our speakers. So first of all, let's welcome Dr. Rupesh Rena, who is past president of APNO. Dr. Rena is adult pediatric kidney disease specialist practicing at Akron Children's Hospital and Akron General Medical Center at Cleveland Clinic. He is associate professor at NeoMed Medical University and Case Western Reserve University. Additionally, Dr. Rena serves as a board of advisor at the National Kidney Foundation. So let's welcome Dr. Rena.
Thank you, Dr. Mehta. First of all, thank you, Dr. Chen and Dr. Date, for giving your evenings on Friday, so I can understand how valuable your time is. So I think I was given a task about talking about the pediatric spectrum of the COVID-19. And being an adult and peds, we have a very good spectrum that we can see. We actually had a paper coming now in blood purification that we did the systemic review in adult, and we found out what are the incidences, how many need the dialysis. Is pretty intense. Peds is a very different spectrum, and we have two papers now coming, is what we call that as MISC. Dr. Chen must have seen that more. It's a multi-inflammatory systemic response. It's actually behaving almost like a Kawasaki disease, and with the involvement of cardiac. Children were not being also spared with this, but there are some theories that they get less infections because they have less ACE receptor development, which is also controversial. They're more protected. Come in my world, how the mothers, they protect their children when they see, and their exposure is bare minimal, and their immune system is very hyperactive. So I was talking to Dr. Chen. We have Pfizer, which has approved, or they're in the process of approval, giving the vaccine for 16 years and above. And now the trial is it right, Dr. Chen? They have completed between 12 to 15. Is that right? They have done the enrollment?
That's right. I wasn't involved in those studies, but they've completed enrollment for that adolescent trial.
Right, thank you. And so we are going to look into the data. I'm going to review at it, but its speeds are very different because their immune response is very, very subjective to each patient. And they're very naive. Their B cells are very naive. Their chemokine response is actually very naive. But in children, we are seeing a total different spectrum. And we have around 2 million cases. When I was writing a paper 2 months ago, 2 million cases and 200 deaths. AKI was like 5%. Need of RRT was very bare minimum. I have my fellows here, Ronit Chakravarti, and I have Krishna Mukunda, who worked with me a systemic review and blood purification. So the things for children are also not safe. Don't think they will eventually get sick too. And we have a lot of transplant patients, and mothers are very aggressive, and they want to get immunized because that is another whole area of investigation. But we came up with the guidelines where we suggested that they should be immunized. despite being an immunosuppression. So things are evolving in children's, but totally different spectrum as compared to adult and peds. And the kids, they get better, and when they get sick, especially the one with heart transplant or double lung transplant, cystic fibrosis, they really do bad. So it's just how your immune systems are wrapped up, but they are not out of the loop of the infections, but it's a total different phenomena of vasculitis, coronary aneurysm, which is different than the adult spectrum. So I'm looking forward for the data, and we will have a meeting very soon to review the data from 12 to 15 years of age. I'm not pretty sure that we will advocate the vaccination early. It will take a lot of side effects and other things. So, but stay tuned. We will definitely get some answers for you. Thank you, Dr. Mehta.
Thank you, Dr. Reena, for updating the pediatric population. Now I'd like to invite Dr. K.V. Gopal to talk about this vaccination in adult population. Dr. Gopal Krishna is a Chair of Department of Medicine and Chief of Infectious Disease at Fairview Hospital, Cleveland Clinic. He is Clinical Professor of Medicine, Lerner School of Medicine. Please welcome Dr. Gopal.
Dr. Gopala, you're mute. Dr. Gopala, you're on mute.
Sorry about that. So thank you very much, Dr. Chen. It was an excellent presentation. You made it very simple to understand the vaccine production. And actually, many people have asked me as to why should we trust this vaccine, which has been prepared so quickly. But my answer to that was, this is a medical marvel. You know, it's actually, you ought to be really proud of the fact that we are able to get that vaccine prepared so quickly. I don't have much comments, but I just wanted to make sure that the questions continue to come, and maybe Dr. Chen can answer this. The availability of the second dose of the vaccine sometimes becomes an issue in our distribution of the vaccine. And the timing of the second dose, the Pfizer and the Moderna, which is available, that has to be exactly 4 weeks or 3 weeks, or is there a leeway? Have we understood right now? Can we get this second dose of the vaccine? Don't have to be exactly 4 weeks or 3 weeks. Is there any clear answer, Dr. Chen?
Yeah, this is a good question because I get it a lot as well from my medical colleagues. And so the answer is, these vaccines were developed and studied in the dosing schemes that you saw. So 21 days for Pfizer and 28 for Moderna. Now, I don't suggest that we administer these vaccines closer together, because we do know, and we know from many other licensed vaccines and other vaccines that were developed, where if you space the interval too closely together, you can actually get a reduced immune response. So there's something about the maturation of the immune response, which is, again, if you go back to your first and second year of medical school, there's this maturation of the immune response that needs to happen that allows you to have higher affinity and avidity of your antibody response, and it's your B cell maturation process. So that also happens on the T cell side as well. So in other words, we do know that when you space 2 doses of vaccine further apart, that it actually does not hurt the immune response. So my recommendation has been, and what the CDC basically says, is that you have a grace window of 4 days to give the vaccine a little bit earlier than what is indicated. So for Pfizer, 21 days, but then you can use a 4-day window. You can also separate the doses, and this is also advocated by CDC as well, further apart if you want to. Now, the CDC doesn't want them to be much further apart. Six weeks is, I think, what they state currently. And before that, they said indefinitely it would be okay. But the point is that you still want to give the 2 doses, because we only have really good data for the full efficacy after 2 doses instead of after a single dose. So what I'm trying to tell you is that we need to balance out our ability to administer those 2 doses by being flexible around the window, but being flexible on the positive side, but not trying to use the window too closely so that we space the 2 doses too close together. So in other words, I'll just summarize. For Pfizer, I would suggest giving it 21 days apart or longer. And for the Moderna, 28 days apart or longer. But keeping in mind that trying to give that second dose is important to confer the full amount of immunity possible to that individual. And so the shorter period of time that they're at risk for exposure to COVID is to their advantage. And that's why we try to space those two doses as closely together as possible within the windows that we've already defined. Does that make sense?
That's a great answer. That's very good. I think that's one of the many questions have been asked by our own healthcare workers as to when can I get the second dose, and that's a great answer. The one other thing which I think Paul Sachs has written a very nice editorial in New England Journal of Medicine about the transmissibility of the virus after receiving the vaccine. And he says that there is really no vaccine now we are giving will prevent but not stop the transmission. So why this vaccine should be any difference? Do you have any comment on that?
Yeah, that's right. I think that, to expect a vaccine to completely eliminate transmission is kind of expecting a very high bar from these vaccines that we develop so quickly. Again, like I say, I was expecting 50% or better for a vaccine to be valuable to us, and so we really hit it out of the park with a 95% efficacy. I would have accepted 70% as the best. So again, going back to the value of the vaccine is not in having whether or not it interrupts transmission. It's really whether or not it interrupts the most important part of the disease, which is hospitalization and death. And even if we have vaccines that allow a person to become exposed and have symptomatic disease, as long as it doesn't progress on to hospitalization and death, I think we're still being successful as a whole with trying to get us out of the pandemic situation.
One of the last question from me, and just a comment, is the public health, as you have shown in your slides, that sort of the priorities wise, the age and elderly patients with the nursing homes and the healthcare workers, that's the priority have given. But and I'm an infectious disease physician with a lot of HIV practice. And a lot of my HIV patients are asking, I'm only 35, 45. Why am I not included in that priority? I know I'm telling them the answer is, your time will come, just wait. Is that the right answer? Or are we going to, public health is going to introduce some kind of a combination, not only the age, but also some immune diseases to be included in the phase 1C or 1D?
Well, I think that this person would be among that priority population, which is the 18 to 64 years of age with a comorbid condition. And so they are part of a priority population, but they're not at the top echelon. So let me also explain about the priority populations and how we thought about them as well. Because under the ethical framework for rolling out these vaccines, we needed to, first of all, protect the healthcare workforce that was taking care of severe COVID. That's why we had healthcare personnel. Then we realized that the huge burden of mortality was not just among older adults, but among older adults that were stuck in congregate living settings where they couldn't control it, but you had these huge outbreaks with high morbidity and mortality. So that's why they're among the top. The second tranche, of course, continues to still be age-based, but we also included frontline essential workers. And that's because society needs to function. And what are the critical parts of society that allows us to continue on? Well, that was set forth by CISA, which is the, I think it's a Center for like Cybersecurity or whatever. They basically have a guidance document that talks about critical sectors of all different areas that are important for homeland security and for society to function. And that's, like agricultural, manufacturing, transport, first responders, those sorts of things. Again, if we don't have these people, society falls apart. And so those are the people, again, that we need to be able to have them go to work because they don't have the ability to, their occupations are not telework occupations. These are occupations where they have to be out there in the field or do what have you to make our society thrive or continue on. So again, that's why they're a priority population, because otherwise without them, we can't function. Then you go on to the next, tranche, which is the people who are at high risk of severe disease. And so again, going to the adults that have comorbid conditions. And then finally, after that, then we open it up to the general population. So again, seeing that ethical framework, your HIV patient is not, we're not saying that they're not important, but we are putting them in a prioritization line where, again, if we're thinking about humanity at risk, and we are at the precipice of survival and perhaps not even able to survive, that's how we basically said, well, this is how we need to have this happen. So anyways, I think people have to understand and be patient about the fact that there are limited doses. Everyone is frustrated about the way that these vaccines are being allocated. And again, I think that, again, we have limited vaccines that are coming in from the manufacturers. Originally, they had projections that they would have multiple millions of doses per week that were being delivered, and then they had problems. So again, we continue to see that on a global level. So we're getting allocations at the national level that are much lower than we originally were expecting with our projections. So again, I think that causes a lot of frustration and anxiety across all of the population of the US, but we need to kind of back up and be reminded that, again, at the end of the day, we're talking about the survival of the human race, and we need to be a little bit patient. For those of us who are able to telework, we need to continue that. For those of us who are able to continue to do the physical distancing, hand washing, wearing masks, we need to do that until we have enough vaccines available for the entire population of the world.
That is fantastic. Dr. Dharmesh Mehta, I will give the podium to you. Thank you very much.
Thank you so much for this good question answer. Now I'd like to open the forum for question answer. So Dr. Reina, can you take over?
Yeah, I will be a little bit running out of time, so I'll pick up some of the quick questions, which is pertinent. First of all, a lot of compliments to Dr. KASHMIRA Datte and Dr. Chen, excellent presentation. Some of the students here are actually going to the reservations to give a vaccination to them. So they're pretty happy, and this is very nice presentation always. So first question, I will give it to Dr. Datte. This is a tough one. What would be the reason for low death rates in India, and why even the cases are getting less now?
Thank you for that question. Yes, I tried to answer that in the chat a little bit. It's really hard to tell what the exact reason is. There could be a combination of multiple reasons. First, we already know that the number of cases that are reported and number of deaths that are reported only represent a fraction of what's reported. And we don't know what the extent of underreporting might be. That might be one reason. Another reason might be that, we already know that India has actually implemented a lot of mitigation policies and, the public health and social measures like mask mandates and other implementation of mitigation measures. So that could be a contributing factor. The other thing could be that, we know that there are a number of seroprevalence studies that have been done in these settings. And in some of the urban settings and slum settings, we have seen seroprevalence as high as 50 to 70%. So it could just be that a lot of people are already infected, and that may be contributing as well. So it could be a combination of multiple reasons.
I have another question for you, Dr. Datte. Thank you. Statistically speaking, what does 95% efficacy means as opposed to 70% efficacy? Does it mean one is better than the other? I hear that all the time, all the time. Even I was debating to take Pfizer and Moderna. At the point I said, whatever I'll get, I'll just take it at this point of time. Efficacy is a pretty broad term when it comes to that definition. With the treatment and when you go for the trials, it's like FDA loves the efficacy, and these are pretty wide variables. So I'll defer it to Dr. Datte or Dr. Chen.
So actually, I'm going to defer it to Dr. Chen for that question. But before that, I just wanted to quickly mention, Dr. Chen gave a really great presentation in terms of efficacy and what we are seeing. The one thing that we have to remember is that these are the estimates, or this is what we are seeing from the studies, the clinical trials on direct efficacy of the vaccine. So when the vaccine gets actually implemented and more widely distributed, what we call as coverage, and the field effectiveness of the vaccine may be different. There is also indirect protection that may be offered by the vaccine. So when a large proportion of the population gets vaccinated, we actually see that indirect protection for people who are not vaccinated. So with that, I'm actually going to turn it over to Dr. Chen to answer that question.
Yeah, that's absolutely right. So I think, again, so let's talk about efficacy again. So when we talk about that 95% or 72% with the Novavax or the J&J, I'm sorry, that is really talking about protection against symptomatic disease, just symptomatic lab confirmed disease, which could be as bad as a sore throat and a cough. Now, that isn't what me as a physician am worried about. I'm worried about, again, deoxygenation, hospitalization, death, ICU stays, those sorts of things, or the complications where you have clotting, where there's MI, stroke, or whatever, right? So those are the real medical effects that we want to prevent. So again, when you look at the studies specifically for those outcome measures, which is not the primary outcome measure, but it's nearly 100%. So actually these vaccines are far better. And in fact, if you look at all the other studies, again, for the publications that I've seen so far, I have not seen any severe cases among vaccinees. So again, that gives me confidence that these vaccines are very good. So I would say, that 70% versus 95%, I wouldn't really be so concentrating on that. They are all valuable vaccines, because even that 72% efficacy vaccine, the J&J, is a single dose vaccine, which means you can give it to people much more easily, especially those difficult to reach populations. So again, the value of the vaccine is no different. In fact, I might argue that it actually is even more valuable in our hands, public health hands, because we can get to more people much more quickly and we can immunize more of the population, okay? Now, going back to Dr. Date's comment, which was the indirect effects, she and I actually, when we're not doing COVID, we're doing enterics research. So we both actually share that space as well, with studying cholera, Shigella, ETEC, typhoid. So in cholera vaccine, there is this huge indirect protection that you see. When you start immunizing 50% or more of the populations, you see huge declines of cholera cases in that population because of the indirect effects. So we may see that, again, I bring that up because as we deploy these Moderna and Pfizer vaccine, and eventually the J&J and other vaccines into our populations and start achieving high levels of vaccination, 50% and then up to 70%, I'm hoping and expecting that we'll see huge drop-offs in cases and transmissions, such that hopefully by the end of the summer, if we can achieve 70% or higher immunization rates, we actually might be able to open up fully, because I'm hoping that we will see those indirect effects as well as the direct effects cumulatively, and that we will actually be able to have near elimination of cases in those localized communities. So, again, it's just my way of saying I'm so enthusiastic about these vaccines. I just cannot tell you.
Right. I think, Dr. Chen, most of the people, when they talk about efficacy, they don't look into the crude points of the morbidity that is associated. They just think in the perspective of the seroconversion, and they don't look for the crude outcomes. And, most of the time I've seen during the epidemic, like patients I see them in the ER by the time they're on BiPAP, and they come in 6 hours, they are in ECMO, and the rapid progression. So that's a very good point. The efficacy is not seroconversion, it's the crude endpoint that, and FDA is very particular about that. There's one question I'll take, and I'll try to round up, but before I take that question, Dr. Date and Dr. Chen, are you okay to take 1 or 2 questions? I don't want to take your time. It's dinner time, so I just want to make sure. Okay.
I'm okay.
This is a good question, actually. And the question is from Dr. Dozina, if I'm saying the name correctly. I have observed worse vaccine reaction in those who have COVID versus those who have not. Are 2 mRNA vaccines necessary in those who had the illness? Seem like one vaccine might boost up the COVID survivor immunity, and there would be more vaccine available for the non-previously affected throughout. This is very common question people ask. And with that, I will add one more question now, which I have asked you earlier. What is your time frame from the infection and getting a vaccine? Because there's another question is, if you got an infection, how long you have to wait for the vaccine?
Yeah. Well, for the first question, that's actually a great question because they just started a study in the UK to address that. So for people who have had the natural infection, they're trying to see if they can deliver a single dose of the vaccine and still achieve the same level of protection. Because again, immunologically, you've already been primed immunologically with the natural infection. And so you're coming back with what we call a booster with the immunization, with the vaccine, with the single dose. So it is possible, and it is, maybe achievable. I just don't have data to substantiate whether or not it will actually work. Because what we want to see is not just protection, but we want to see enduring protection, long-lasting protective immunity, instead of what we see with natural infection, which is relatively short-term immunity in some cases. In some cases, again, it drops off within a month that you start seeing declines in neutralizing antibody and convalescent serum. Okay, so but most of the time we see that the protection lasts for 3 months. So that brings me to the second question, which was, how long after natural infection should you get vaccinated? And that goes to, the data suggests that most people after natural infection are protected, at least for the short term, for at least 90 days after natural infection. So the CDC guidance right now is, if you know you've had an infection from COVID, that you may wait for 90 days before getting vaccinated with your first dose. Now, that's not a strong, it doesn't say you cannot, and no one is policing it. So that means if you're a healthcare worker and that you work in the ICU and around COVID patients, and you had a natural infection a month ago, and it's your time to come up, and you've of course fully recovered, and your hospital basically said, oh, you're next, you have an appointment for your vaccination. You are not mandated to have to wait for another 2 months for that 90-day window. You're allowed to use it if you want to, but nobody's enforcing it. So in other words, it allows the local jurisdiction to have flexibility to deprioritize those people, to let other people in the healthcare force or maybe in the long-term care facility to be able to be immunized first ahead of the line before that person. But that person still should be immunized. And so again, I just wanted people to understand that there is local jurisdictional flexibility around that guidance of 90 days.
Thank you. I think there was one question about whether these can be given into immunocompromised host. We have a mandate from the ASN, American Society of Nephrology, and International Pediatric Nephrology Association guidelines are coming. We are giving it to the immunocompromised host. And I think that's not a concern. There was also some question from Dr. Winnie Macon. She's actually our upcoming president-elect, that she was asking about what's the difference between Pfizer, Moderna vaccination, and the various JJ vaccine. Again, efficacy, as you know, Dr. Chen, when we go to the FDA, it always reminds me when you go to FDA, it's like you're talking to your mother-in-law, whatever you say, you will be wrong. So efficacy is a crude endpoints. These are not seroconversion. So I think we kind of answered that. And I don't think we have much. There was one question like, they're asking how long the efficacy lasts. I think it's an evolving term, and you exactly nailed it. If we can do 70%, we'll at least have some life with an epidemic, and that's something is evolving. Data is coming on, so I'm not going to put you on that spot. And with that, there's a lot of comments about your presentations, and I can go on saying about all that. And there is also from Dr. Khatri that Is the current guidance, also recent papers show that people with COVID-19 get adequate immune response with just the one dose. I think you have already presented that in the data. It's against the seroconversion and the endpoint. I think at this point of time, I'm not gonna put a lot of questions on you, but these are very relevant questions we see all the time. And we just did actually a ISN, International Society of Nephrology, and IPNA combined presentation where we were talking about immunosuppressions. And the data is very, very strong. They don't get much effect. And I think Dr. Sonia Sandhu is here. Dr. Dalbir Sandhu is one of our executive members, and she has shared with us their oncology guidelines that they are recommending with the patients on chemotherapy. So that is something good to move on. With that, I will give it to Dr. Mehta. My personal thanks to Dr. KASHMIRA Dete and Dr. Chen. Thank you for giving your time on Friday, and thank you for delaying your dinner on Friday, but that means a lot to us, and we have been interacting in various forums and research, and thank you for your time, and this is very valuable. My students are very happy. Everybody's sending me a lot of messages. I will definitely send you that as like a thank you letter from Dr. Mehta, who is our president. I will defer it to Dr. Mehta for closing remarks.
Thank you so much, Rupesh. Yeah, like we really appreciate Dr. Date and Dr. Chen for spending a valuable time with us, and then on behalf of Executive Committee, I would also like to extend my gratitude to both of you. And it was very good information. Like we learned a lot during this, a lot of good conversation. So I would also like to thank you everyone for joining us tonight. And then please be safe. It is very important time. So, and everyone have a good night. Okay. Thank you.
Thank you. Thanks a lot, Dr. Mehta, for an excellent, valuable seminar. Congratulations. This is his first opening seminar, so it was very well taken. Thank you.
Thank you.